All right, let's kick off our webinar. Good afternoon, everyone. I'm Sam Peck. I'm the Executive Director of Family Councils of Ontario, and I am so glad that you can join us for today's webinar, Humanizing Dementia Care in Long-Term Care, which is co-hosted by FCO and CARP Ottawa. Before I turn it over to today's co-host, we're going to start with a land acknowledgement. Acknowledging the land is a traditionally Indigenous protocol, and it's used to express gratitude to the peoples who reside on the land that you're on, and also to honor the Indigenous peoples who have lived, worked, cared on this land historically and presently. It's important to understand the longstanding history that has brought you to reside on this land and to seek to understand your place within that history. Land acknowledgements don't exist in just a past tense or historical context. Colonialism, Indigenous rights, it's an ongoing process. And together we can build our understanding of our present participation. I'm coming to you from Hamilton, and that is situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. It's also land that's covered by the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and the Anishinaabe to share and care for the resources around the Great Lakes. FCO, we're a remote team, and we work across the province. And we encourage our team members, service users, and our partners to reflect on colonialism's enduring legacy and engage in meaningful reconciliation. A place to start, it's certainly not a place to stop, is to learn about the territory your home is situated on. You can visit a website that's Whose Land or Native-Land to learn more about the peoples, languages, treaties, and more of the place that you live. The work that non-Indigenous organizations and individuals need to do towards meaningful reconciliation with Indigenous peoples is a long-term journey. It's specific to each individual, and it's constantly evolving for us and our organization. But we hope that you will join us on this journey. A few technical notes. All of the attendees are muted. You can put your questions in the Q&A section, and if you have any technical issues, please message the host via the chat. It's now my pleasure to introduce today's co-host. Claude Paul Rovin is the CARP Ottawa Chapter Chair. He's going to provide opening remarks from CARP and introduce today's speaker. Claude, over to you.
Thank you very much, Sam, and good afternoon, everyone. First, let me say how delighted we at CARP Ottawa are in collaborating with Family Councils of Ontario in organizing this important presentation today. CARP Ottawa's top priority is transformative change in long-term care. And through our advocacy working group on LTCs, we are always prepared to join our forces and to join our voices with those of other like-minded groups to achieve this goal. And today, we are so pleased to have as our speaker, Aimee Foreman, an entrepreneur and an advocate committed to advancing the quality of life for older adults. Aimee, thank you so much for accepting our invitation today, and the floor is yours.
Thank you so much, Claude, for that warm introduction. I truly believe we're here to find where we share values and come together, and you framed that up so nicely. So thanks so much to CARP Ottawa and to Family Councils of Ontario of inviting me to spend a little time with you today. I'm going to share screen and use a slide deck presentation to talk about the topic of the day, which is really humanizing dementia care, and particularly highlighting the Hogeweyk model and how we can apply learning and insights here in Canada. So bear with me for a moment while I share screen. Wonderful. So As I mentioned, happy to be here in this webinar. I'm going to talk for a little bit, and then I know we'll have Q&A, and as encouraged, feel welcome to put your questions in the chat, and we're going to open the floor at the end, I believe. So today in our time together, I'm really going to break down the discussion into 3 pieces. I'm going to talk about insights, 3 insights about the Hogeweyk model. I'll then share 3 insights about long-term care in Canada, and then lead us to 3 insights that can really inform how we transform long-term care and caring for older adults in Canada, in our country. So we'll take the discussion in chapters today. First off, I'd love to introduce myself. As Claude mentioned, my name is Aimee Foreman. I'm the founder and CEO of Silvermark. We're a team and based out of New Brunswick. So I'm coming to you today from the East Coast, and I'll share a little bit about our team's approach and how we were able to come connected with some of your peers here within CARP, and what led us to joining today's conversation. So first off, about me, one of the things that I'm often cited to say is that aging is not an illness. I absolutely believe that we often over-clinicize aging. We certainly have institutionalized aging, and we juvenilize aging. And so the underpinning for me of all of this purpose-driven work is really this belief that aging's not an illness. It is the one social condition that is universal to all of us. And so when we think of it in that context, when we think of aging as a social experience and not a clinical or healthcare experience, then we can really start to think about social care and all of the things that support aging well that are as important, if not more important, than certainly quality care in a healthcare setting. And so I think that's going to speak to some of the values and beliefs, and I know the language and pursuit of emotion-based care and relationship-based care that a number of you are party to. So I suspect we share that value right from the onset. But this is how I like to frame it to people. I like to remind people that aging is not an illness. There are beliefs that our team and I personally hold. They've certainly were influenced originally for me by Dr. Bill Thomas. So some might be familiar with some of the phrasing here from his work. He was the founder of the Greenhouse Project and also the Eden model, which I know many of you are familiar with. The greatest plagues to aging well are loneliness, helplessness, and boredom. And the antidotes to those, or the solutions for those experiences, can be found in connection, purpose, and meaningful contribution. So when we work on projects, we really look through that social lens of the experience the experiences we have when we're aging, and try to solve the challenges in front of us in solutions that are rooted in connection, purpose, and meaningful contribution. Ultimately, we are trying as an objective in our team to humanize decision-making that drives investment and innovation to improve quality of life for older adults. Claude mentioned that when he was introducing me, that is the common thread. We're very purposeful in choosing to work in the aging care sector specifically, again, because we're all aging, and we think this is, if we can humanize the decision-making in this sector, drive more investment and innovation that is coming from what people want and need in their lives for their own quality of life, then we can make some real transformational change, excuse me. And then the last piece of this is just how we do this. And really, we work with aging care leaders. Those are providers. We work with policymakers and government. So we work for all sides of the sector for those who are serving older adults. And we guide them through our process to really make decisions based on quality of life. So we have a proprietary process, and it's driven to really making humanized decisions or applying a human lens to decision making when it comes to policy, investment, design, all of those things, depending on which collaborators we're working with at a time, and we work across the country. For me, it's a very personal experience. Pictures there of some of my family. So the largest one there on the right hand of my screen was of my grandma Shreenan. So that's a picture taken back when I was in my 20s. My grandma Shreenan experienced dementia, and so thus we as a family experienced dementia. I had the honor of really being with her and holding her hand as she passed away just a few days before our wedding. And that experience left a huge imprint on my life, probably one I didn't really understand in early adulthood, but is really the reason why I work in the sector today. I've taken my experiences in real estate and business and community development and chosen to really lean into a sector that affects us all. And then I always love to share that my husband's grandmother lived to 106. So you'll see our children there celebrating that 106th birthday on the screen. And we live on the East Coast because all four grandparents to our children live in this area. And so it's really important for us to have that intergenerational connection on a day-to-day basis. So many of us I know come to the sector and to this work and advocacy through these kinds of family experiences. And for me, I try to keep that front and center and really remember that we're working for that quality of life. So lastly, just to put it in context and how I was connected with some of your CARP fellow peers here on the call was this past fall in October, I had the pleasure of joining the founders of the Hogeweyk model. So from Netherlands, Eloy van Hal and Jeanette Spearing, who are two of the co-founders of the model. We have formed a partnership and collaboration, and we decided to embark on a Canadian tour. So we actually visited 5 cities, including Ottawa and also Toronto and Ontario, and really talked about humanizing dementia care. So I'm going to pull a little bit of snippet from some of the things on that model, and as I said, then share them as learning and insights as to how we can apply what really the Hogeweyk model has accomplished as really the world's most famous nursing home in many regards, and how that should be informing transformation here in Canada. So the Hogeweyk model, or commonly also referred to as Dementia Village, you've probably heard it by that name. I think it received that name when it was featured on CNN a number of years ago. The Hogeweyk model, I'm going to talk about 3 insights. I'm going to just speak a little bit about the environment, so the socially built environment, the design of the home and village. I'll talk a little bit about the model of care and what is emphasized. And then I want to put it in context as a regulated home and just give you a snapshot of this home is in the Netherlands, just outside of Amsterdam. And, you know, what does that mean in the context of regulation there? And how can we compare that apples to the regulatory environment here in Canada? So first off, I just will guide you through a few pictures. This is the town square of the Hogeweyk. And when you walk out here, it is indeed vibrant. I know when I was there last May, it was as sunshiny a day as you see here on the screen. And, you know, things that you'll notice are, you know, fountains and plantings and different green space. You can see back here, this red sign, that's actually the sign for the pub. This is yellow sort of stand-up building here. This little pillar is it's where they say what's happening in the town or the village that week in terms of activities and social clubs and things. But one of the things I would point out is that at first glance, it's really hard to notice who lives in the village, who's visiting, who works, and that's partly because of plain clothes and nobody's wearing uniforms and name tags and things. And I'll talk about that a little bit later again when I talk about Canada, but it really is a very different feeling when you enter the village, i.e. the home. You enter it through this square, and although it is secure from the outside community, it is indeed a village where people have a lot of freedom to move around the space, both inside their households and the green space and amenities. Here's a peek inside the homes. So the homes are 4 different unique designs because they really follow a model of lifestyles. This is a particular design of a traditional Dutch home. So the actual households, so that 7 to 8 residents reside in the households, they are designed differently. So you might be familiar with trends that look more like walking into a hotel in some of our new long-term care homes. It is very much the opposite of that. When you walk through the households at the Hogeweyk, they look like the homes that we live in our own neighborhoods and on our own streets. And this one is of that, as I said, that particular Dutch design. They have done that through a curation, both in found objects, resident objects, but have put a lot of thought behind the aesthetic of the actual households. And lastly here, I just point out there's a reference to the green space and moving around. You'll notice the fountain, and you'll notice some stones here, and there's some cobblestone aspects. There's a lot of different little green spaces, outdoor spaces. That's probably the hardest thing to describe without being at the Hogeweyk. People can become familiar with the household model, and probably many of you are through the greenhouse project and some of the other models as well. But it's the intersection of all the green space, and that you can really walk through that freely, and that you can have choice in how you spend your time, and whether you're cycling around or walking around or just enjoying sitting by the fountain or the bench. It's definitely very intentional how much emphasis has been placed on the exterior of the households as much as the interiors. And that would be very different than how we often look at designing homes and access to outdoor space. We think of it as just access to outdoors and almost a design requirement, where for the Hogeweyk, it's fundamental in everything that they do, because you do all the activities and things outside of your home. So just a few pictures there in terms of inspiration. I will talk a little bit about the model of care. So a few things that are really important to note, and one of them I just mentioned, is that the activities of daily life, they really happen outside of the household. So this is a snapshot of the grocery store, and you can see a resident here with a caregiver, and he's visiting the grocery store and picking out groceries and supplies to take back to his household. So anything that we normally leave our household to do, at the Hogeweyk, you also leave your house to do. So if you're going to enjoy a concert or pick up some groceries, or go to the pub, or go to a club or an activity, those things happen outside of the household. Inside the household, the activities of daily life that we also enjoy in our household, like cooking and laundry and just having a cup of tea and reading the paper, those happen inside the household. So that's a really distinctive element of where the design of the home and the model of care come together. And certainly is one that has not been really well replicated in terms of, you can see the expanse of this grocery store. It really serves as their inventory control, and a lot of emphasis have been put on that. Here you can just see that purview inside. You have a resident and a caregiver who are preparing dinner. So those meals are prepared in the household. That's an activity that you and I do in our home, and it's an activity that is normalized and carried on inside the households at the Hogeweyk. And lastly here, this is just another nod to outdoor space. This gentleman, this is his favorite little woodshed to enjoy his cigar. And so there's outdoor space available outside of each household, but also throughout the village. And a lot of choice is offered in that, in terms of those outdoor spaces and the freedom to be able to enjoy them as residents wish. And so the last, I just want to give you some clarity on the regulation of the home. And so first and foremost, there's a difference in the approach of the home. The approach is that resident autonomy and self-identity trump institutional efficiency. And when you look at those pictures, often what Eloy says when he's taking a study tour through the home or leading people on a tour through the home, he'll challenge us to find the nursing home in those pictures or in that experience if we're walking through. The pictures I just saw you are real pictures. They're not staged pictures. And there were no institutional cues, right? There are no fluorescent lights. There are no uniforms. There are no handrails. Even though this is a licensed nursing home. And it's really important to recognize that in the Netherlands, the Hogeweyk is a licensed home and is under the same regulation and the same funding model as the 2,000 other nursing homes in the Netherlands. And that's the important aspect to be thinking about when we look at learning from a model outside of Canada and bringing it to Canada. People often want to know, well, how much does it cost to run, and what is the staffing complement, etc. But the apples to apples comparison shouldn't be how do they do it at the Hogeweyk and how can we do it in Canada. It's the fact that they're able to do it in the same regulatory environment with the same budget and the same requirements in the Netherlands shows us that you can transform in that regulatory environment the same way you can do so in Canada. We can apply that same practice and learning. So the only other thing I'll say about that in terms of the regulation and the profile of the home is often people are hesitant to believe the acuity level of those residents that were just pictured. And the Hogeweyk serves only those with advanced dementia. They are residents that require complex care, 24/7 support, and are no different than those folks in Canada with dementia. Dementia does not discriminate one country to another country. And so it's really important, and that sometimes can get lost in sort of looking at the photos and experiencing the home, that it truly is a regulated, licensed nursing home, akin to the same types of regulations that we have here in Canada. So that's going to lead me to talk a little bit about long-term care in Canada. So I'm going to again give you, take this in 3 parts. I'll talk a little bit about some learnings and some precedent homes, just in case you're not aware of them. So we know that they've been inspired by the Hogeweyk, and so we can look to those for even deeper learning. I'm going to talk a little bit about language. I know that's something many of you folks have spent time on in terms of the evolution of person-centered care to relationship-centered care and emotion-based care. So I want to speak a little bit about, really in practical terms, how we can be cognizant of changing our language as we pursue transformational change. Excuse me. And I want to talk about the opportunity that I think exists in Canada, and what will that take to accomplish what I think probably everybody on this call shares in terms of a vision and a desire to improve quality of life in Canada for older adults. So first up, just a couple of snapshots here of homes. This is a home, this is the village Langley in British Columbia. It is a home that has been inspired by the Hogeweyk. Its founder, Elroy Jefferson, actually heard and visited the Hogeweyk model, and it inspired him to really look at building something that provided many of those same principles of normalizing daily life for those with dementia or those with care needs, certainly employs the household model, and has replicated some of the things like the grocery store even that we just looked at, although on a smaller scale. And Elroy is a wonderful gentleman with a very clear vision. He understands and is quite humble that the vision perhaps hasn't been fully achieved yet, but this is a tremendous step forward in terms of the design and operation of a home here in Canada that we should all be looking to. It is a private pay home, and I think that's part of why people have been hesitant to say, can we actually replicate and scale this? But I would challenge us, and I know I'll be spending time this year with Elroy to really kind of close the gap on that, because the numbers are not that different when it comes down to the financials and certainly the operating model with the staff. And again, this home has spent, and this design has spent a lot of emphasis on the exterior design. So this is one picture, and you can kind of see the pathways, but these pathways exist all around these homes. There's a little hobby farm with some animals at the far end, and trellises and gazebos and a little pond, and lots of choices to enjoy the outdoors. And to at the same time, they are keeping smaller groups of elders in these households, both in assisted living and in dementia care. So encourage you to take a look at the Langley model, and happy to share more about that in the future. This other one, I just wanted to give a snapshot from an East Coast perspective. This is Tideview Terrace in Digby, Nova Scotia. It was actually built around 10, 15 years ago, but you can obviously see from the overhead picture the households, and it was inspired certainly by the greenhouse project model in Hogeweyk, and it was a result of the Nova Scotia government at that time putting out a procurement where they wanted households to be developed in their nursing home models. And so it's one of the very successful homes, one of the smallest groupings of elders that we have in Canada, with groups of 9 and 11, and is a licensed nursing home as well. So just in an indication, we have here a nonprofit home, publicly funded, accomplished through a procurement. So very different than the Village Langley and how Elroy pursued this. But Deb Boudreau, who's one of our collaborators and the administrator at this home, also has a wealth of information to share and learnings, and it just demonstrates that we have precedents here that we can point to, especially when we're advocating to Canadian policymakers, funders, decision makers, even our designers and developers and owners and operators, to say, no, there are homes we can look at in the Canadian context that can inform our planning and development. The second, I just want to speak about language. One of the things people struggle with is how to start, and I think we really need to think very simply, and language has a lot of power. And it's clear, as I said, that your group has spent time on this and how you've been advocating. But these are all references back to the Hogeweyk model for today's topic discussion. And one of the things that is the theme, the fundamental theme of the Hogeweyk, is normalizing dementia and really creating a normal life. That is the vision of the founder, Jeanette Spearing, and she's held that vision for 40 years. Started out in a previous home and then was able to build the Hogeweyk, and Eloy came into the fold as well. But when they look at the activities, the things that you enjoy outside of your household, part of it is the language. And here, in many cases in our homes, we've tended to we're a very checklist environment, very task oriented sector, and we've made sort of person-centered care or emotion-based care sometimes checklist, and we've kind of named it in certain ways that is institutional or is giving that institutional cue, and we can step back from that. So here's a lady who's just tending to the flowers outside of her household, and can we call this gardening, or are we calling it a gardening program? And so to be conscious of that. Same thing with art. So here's some folks who are enjoying obviously an art class, but do we call this art, or do we call it art therapy? So when we use those words like program and therapy, we're clinicizing the aging experience when we do that. And although therapeutic recreation as a profession and expertise is really important, and valuable, I'm certainly a believer that's where we should invest more when it comes to workforce planning and organizational design in our homes. We need more therapeutic recreations experts. It doesn't mean we have to call it that, right? And so I think being very conscious that we're not using that language and sort of institutionalizing or creating cues that don't need to be there. So here, one of the things I mentioned early on when I showed you one of the opening pictures was that everybody was wearing plain clothes. So this is one that personally I talk about a fair bit, is whether we're getting dressed for work or dressed for a home. And so I would profess that I don't know what the value is in wearing the scrubs in a home environment. If we're trying to create a nursing home or a long-term care home that when you have to move out of your own home still feels like a home, we have to be very cognizant of what cue and sentiment and experience those uniforms incite for residents. If we were to close our eyes and somebody knocked on our front door and we opened it and it was a police officer dressed in uniform, we would have an emotional reaction. We would have a reaction to that uniform. And so it's no different than if we're knocking on someone's home, their room, and we have a uniform on, even the white coat from a physician or clinical expert, that sends a cue, and we need to be really conscious and ask ourselves constantly whether that's necessary and whether that's really driving the values we're trying to offer to residents and older adults on the daily. So I really push people to think about whether they're coming to work at work or whether they're coming to work in someone's home. And often their intention is the latter. And we need to question, well, are we acting that way? Are we dressing that way in this case? Same thing, music therapy is one that's referenced a lot. I know even from my own experience being in direct operations years ago, I was a proponent of music therapy and pet therapy and art therapy. And now I know better. And really music is just music. It doesn't have to have that therapeutic title on it for us to really just lean in, enjoy it, and understand the value that it brings to our quality of life. And this is one that gets a lot of attention in Canada, because when we look at some of the Nordic or European models, especially the Dutch model, actually, there's a real focus on reablement, occupational therapy, and that is becoming more of a relevant conversation in Canada. It's certainly one that I think is really important. But again, do we need to design a reablement program where people are going to occupational therapy and all of those kinds of things? Or can we just approach and offer a model of care that's re-enabling, that inspires movement, that incorporates movement into daily life? So instead of going to the room with the physiotherapist or the occupational therapist and doing the exercises, can that plan, if you will, or that approach just be incorporated in walking around the property, or even preparing those meals like we saw in the slide prior? It's those kinds of things that is a different, it's going to require a shift for us, and a real intention to make sure we're normalizing all of these things. And movement is, of course, as we all know, staying active and moving and just doing things as much for yourself for as long as possible and as long as you want to, that we should be enabling. So I'm going to move to the opportunity here in Canada and what I think we should all be thinking about. As I shared, I was really blessed to travel across the country last fall, and we certainly work in different provinces, but it was really interesting kind of having a similar conversation that from one East Coast, we started in Halifax and we ended in Vancouver, and saying, okay, what's happening across Canada, and what are people talking about, and how do we, mobilize and come together? What needs to happen for us to really achieve the transformation that we're all striving for or all chasing? So I think first and foremost, I would encourage people to answer these questions for themselves. We certainly, this shows up in our process, that it's a small snippet. I've kind of pulled a few questions out of the process we undertake with aging care leaders. But first up, you have to have vision. You have to really be clear and explicit about what you're trying to achieve, whether you are advocating for change in long-term care, whether you are operating long-term care, whether you're designing long-term care, whether you're procuring and funding long-term care or aging care. You really need to be clear about what you want that to look like. What is it going to feel like? How are you going to know that you've achieved that vision? And then be really honest about what needs to be overcome. And for us, we often find people miss who the decision makers are in the process, and really finding alignment with those decision makers. So really understanding what are the priorities from all perspectives. Of course, most importantly, from citizens themselves. What do we all want for our loved ones and ultimately for ourselves? But we often need to sort of overcome some challenges and perspectives, and really sifting through the noise and finding where there's a shared priority is really the linchpin in all of this. And then also how you'll measure success. So especially in when it comes to the context of the provinces, we're really encouraging them to think about measurement more simply. Of course, there needs to be outcome-based measures for checks and balances and quality control. Although I would say a lot of measures today are activity-based measures. That's why I say we're very checklist oriented instead of measuring success. And for us, what we would be most highest proponents of is measuring quality of life. And if you're going to measure quality of life, you have to measure it from the perspective of the person who's living it. And so really advocating or making people, if you're in the advocacy role, really pushing people to tell you, well, if you're going to do X, Y, Z, how do you know you're actually improving quality of life? What are you measuring? What outcomes are you going to report? What are you going to share with the public? So those are three fundamental pieces that really would encourage people to think about. On a very practical side, I mention these sometimes, I've mentioned some of this before, but these are very sort of hot button items, if you will, in terms of the sector in Canada. So I would say, street clothes, not uniforms. And I've already talked about that today. Of course, households, not hallways. Nobody wants to live in a hallway. And hallways aren't just the fact that it's a long hallways with rooms off of the sides. It's also the way that we place wheelchairs or walkers or handrails or lighting. It's all those institutional cues as well that we need to think about. And again, we should be able to walk into a home like the Hogeweyk and not see that. That's the real challenge that has been proven that we all should be up for and should be advocating for. Daily life, not activities. So as I mentioned, daily life, cooking, contributing to laundry, to a household, leaving your home to get some groceries or enjoy a concert. That is very distinctive to the Hogeweyk model and very different to how we program and how we name programming, which I mentioned on the language in Canada. We think of activities, activity department, we have activity directors, and sometimes we play around and make fancy names for those things when really that's all noise, and it's really not helping us just normalize daily life. And that's really what our care system should be designed to do. It should be designed to allow us to stay home for as long as we want, and when we need to move into care, to make sure those homes are as close to the homes we were accustomed to as possible. And I often use the example on that one as a kitchen. And so when you have someone who has been a homemaker, by example, for their life, and then they're no longer able to contribute to meals or setting the table, that isn't an activity that should just show up when they go to a baking club once a week. That should be part of normal daily life. And then lastly, quality of life, not risk reduction. It is a sector that has been, I think, over clinicized. Even person-centered care comes from patient-centered care of a healthcare hospital setting originally. And so we really need to push back on that and talk about quality of life. And quality of life means choice. And with choice comes risk. And, as I'm sure many on the call can appreciate, and certainly what we try to advocate for, is that older adults are simply adults. And really, they're the ones who should be designing what quality of life looks like for them and making the choices, which includes balancing risk that they're comfortable with. So ultimately, we're working to humanize our approach. That's the language we use, is really pushing the fact that we're all just humans. It's all citizens, and really applying that to our decision making. And as I said, to where we invest and to where we innovate. So last few comments here, where can that be applied? Certainly it needs to be applied to policy forming and advocating for that change, making sure citizens are involved in that, advocating for change, involving people. Look, the best practice in any community development, which many of you probably are familiar with, is nothing for us without us. And so you must place emphasis on the older adult perspective. And we have to recognize that we're serving our families and ourselves, especially when it comes to infrastructure. You build real estate for 50 years. These are the homes that we are going to live in. And so really making sure that you humanize that with those folks who are the decision makers when advocating is most effective. And quality of life reporting. So I talked about that earlier and emphasized that really we want to humanize the outcomes that we're looking at and make sure that they're rooted in how people enjoy their lives. So I often ask, if I'm in an audience with people, who has ever said we need to change the system, and raise your hand, and certainly I'll raise my hand every time. That is what we're pursuing when we're really talking about transformational change, and every project, every initiative is sort of tinkering with the system, so ultimately that we can change the entirety of the system. And I really believe we should be demanding a model that centers the individual over the institution, and that creates purpose through a sense of place, a place that is home-like and very familiar, and that supports living a normal life, and really put some truth behind when we talk about a continuum of care. It should really just be a continuum of life, and we as communities and governments and providers should be looking to normalize that. What we have to do in order to accomplish that is recognize we are the system. And so that's why I keep making these references to it's the home for our loved ones and for ourselves. It is our communities. These are lasting decisions we make as provinces start to roll out more dollars. Let's not repeat the mistakes of the past and really evolve to systems change. But you have to do that not by pointing in the opposite direction, but each of us needs to do that and pointing at ourselves and figuring out what we can do to humanize the approach that at least is within our pocket or our bubble or our ability to affect, and certainly to come together. And we've got a lot of people on the call today, so strong group to be able to advocate and really make this reference of we're the system and we want it to be more humanized, and this is how we can accomplish this together. Look, I believe in the right people at the right room, in the right room at the right time. And today is a virtual room, but many of the rooms that I get to spend some time with collaborators with, or with stakeholders, if we can get them to see each other as humans, that's also the first step. And we're able to sort of leverage and use that as a jumping off point for change. But I certainly believe the right time is now. There's been no better time to transform this sector post-pandemic, and still residual effects from pandemic. Put a spotlight on the sector. It has spotlighted issues that we all knew were there before, but it has also done something as a silver lining, and it has allowed us all to experience isolation. And if we think back to those greatest plagues of aging well, being loneliness, helplessness, and boredom, we've all experienced that to a differing degree, especially the loneliness piece. Through the pandemic and the times that we had to isolate. And thus we now have a shared experience, and a shared experience across the world, not just across Canada, of understanding what that feels like. And I always remember a journalist interviewing an older gentleman, and he was asking about that experience of being alone during the pandemic. And the gentleman turned to the journalist and said, "Well, how is that for you? Because that's what it's like for me every day." And so when we can start and position the conversation that way, we can have a different conversation and really put an emphasis on the time needs to be now for this change. Everybody is certainly more than ready, and I think more and more are very willing. Now people just need to be guided in the how. How do they do that? And as I shared, that's what our team chooses to do each day. So appreciate the time. Thank you so much for letting me share some learnings and insights, and contact information is there, and certainly happy to share it widely. But I'm going to turn the baton back to Marg. I know you're going to handle some questions and answers, and I'll also stop sharing screen to that end, Marg. So thank you.
Thank you, Aimee. You've raised some interesting things that we need to think about and also chat about, and the chat line has been active. I just wanted to point out to the very first thing you said, which really struck me, and that it kind of frames the whole discussion, and you did it well. Aging is a social experience, and humanizing dementia care is all about that, and you did it really well. The questions that have been coming in are interesting because, of course, we do things a little differently in Canada, and maybe we shouldn't be. And so some of the questions here are about design. So we can talk about design a little bit here, some of the questions, also activities. And that was excellent in terms of language and being careful on the words we use. And one question that struck me was, how do you propose the calendar to be worded? So you have a daily activities schedule or something. How do you word that then?
Yeah, I think I would really just encourage looking at kind of doing it in steps, if you will. Look at the calendar today. So if you're an operator and you or part of an operating team or care team, strip all the language that is not normal. So first off, just strip it. You're not going to jump from an activities calendar that a staff and a resident and families are accustomed to, and a regulator tells you you need to post it on the wall. So you're not going to like just rip that up day one, but look at it and strip out every word about therapy you possibly can, right? And then I think you need to then, as part of a larger change agenda, really think about, okay, what does the regulation say we need to do? Does the regulation say we need to post that? Does the regulation say, we need to have X activities? How can we approach that differently in this home? Because one of the things that's tricky too in homes is like all the signage, right? Those are institutional cues. Now, a calendar, I have a calendar on my fridge, right? And so can the calendar be in a different place? Can the calendar be in different places? Should the calendar be more personalized to each resident? I would say first off, just strip the language. And then second off, it needs more of a deep dive with a particular team to think about, okay, what would be normal in our home? And can we translate that here in this home?
Okay, thank you. The other question around design on the larger scale, our weather can be really difficult sometimes with our snow and cold weather. How does that affect the design of a dementia village?
Yeah, that's a question we get a lot about Canada. And I showed you the example at Landling Village. So of course that's in BC. So they get some snow, but not probably as much as here in New Brunswick. So that example I showed you in Digby, Nova Scotia, they have created an interior corridor system, right? So, and we've seen examples of that, certainly with the Greenhouse Project. There are many, many plans out there that will show you a corridor that links, and some of that corridor can create some additional spaces to enjoy, sunrooms, windows, the light, all of those kinds of things, to access outdoor when we're not physically outdoors. But I think we need to go further. And I think when we're having design discussions, we have to push ourselves in those discussions to say, how do we deal with the snow in our own homes? Do we go outside? Okay, yes. How? And can we just replicate that experience? So maybe we're not shoveling the snow of the entire green courtyard, but maybe we're still creating a space to get some fresh air every day, the way we might when we're going out and shoveling our steps. And maybe going for a little walk, but it's shorter because it's the winter and the weather and the conditions and things. So it's no question, it's a real variable in Canada that we have to think about. But I think what it's going to take for us to change on the design side for outdoor access is really pushing ourselves in our respective communities, or whichever residents we're looking to serve, is how do we handle the weather now?
Right. There was another question too, getting more definitive down to the bathrooms, for example. How
Yes.
are they configured?
Yeah, so they're private washrooms. I mean, the ideal scenario is private rooms and private washrooms. You certainly have homes in Canada that are being newly designed that can still have semi-private. Sometimes the semi-private is really to support couples living together, or siblings, or best friends, people that have a relationship where they want that proximity. And so they have a shared washroom, but the best practice is private bedroom and private washroom, and the washroom is a full accessible washroom.
Good.
And no question that supports infection control as well.
Absolutely. And that's what we're striving to do here for sure. How many staff would you have, say, for 8 to 11 persons in a home?
Yeah, so that varies province to province, because each province, that's one of the challenges in Canada, is that the lingo, the language, the care hours, the funding models is all different province to province. And so that staffing model really needs to reflect the care hours that are regulated to the province. And when I made that little mention about the dollars and cents, the financing, right? People always say, oh, can this be afforded? And what I would really say is a call to action, or what I'm always searching for, is the province and the operator who's willing to demonstrate this is possible. And I'm gone so far as to say, we're not asking for more money. We're asking for the freedom on how we spend that money. Because right now, every dollar is dictated. Every little dollar you spend is dictated, and it's not outcomes driven. It's activity driven or regulation driven. And if we could get the same envelope of money and work with the right province and the right provider and the right design build team and say, okay, let us demonstrate how this can be done within the regulatory constraints today, because we know it can be done. And that's why I say the Hogeweyk has done that in their own jurisdiction. We now just need the home in Canada is going to do it in our jurisdiction. And so the apples to apples is that it can be done. It's not that we need to replicate their model. We need to find our own and then demonstrate for our country that it's possible. And we haven't done that yet.
No, thank you for that, because a lot of the arguments are around regulations and how can we possibly do it. So it was very good what you just said. So you mentioned about, home like obviously, and staff wearing street clothes, which I think is great, but risk, you talked about choice and talked about sometimes the choices might not be the right ones. We seem to be so concerned with falls. One of the geriatric giants, right, is falls. How is that handled?
Yeah, falls, because falls are the biggest lead to emergency visits, right? And so from an authority or province's perspective, when you think of cost control, they're really thinking with the cost to acute care, and those emergency visits are often something they're trying to reduce. Not only to say the experience of visiting an emergency room isn't necessarily the best experience for an older adult. The way that it's handled in the Hogeweyk model is two ways. One, they have an auditory monitoring system. So if someone falls, it's driven by sound. So not video cameras, not sensors. So we would classify that as a passive solution, right? It's less invasive. And then somebody responds to that. And it's not to say that people don't fall. And it's not to say that the mobility level is any higher. 40% of folks need assisted mobility in the Hogeweyk. Okay, so there are wheelchairs and walkers and all of those things comparable to what we would have in dementia care here as well. But the approach to risk is different, because the objective is not to make the life the longest possible. It's to make it of the highest quality of possible. And it's not even the life, it's just the day. Right? So each day being as normal as possible. So yeah, falls happen, but there is a different cultural perspective, I would say, in the Nordic countries, in how risk is looked at, where in Canada, we're very risk averse. And that's because we've come from an institutional environment. We've come from a medical model, and and we've got to fight against that.
You pointed to obviously the original Hogeweyk model in the Netherlands, and you talked about Tidewater and Digby. Are there any other homes in Canada with this model? Is there anything happening in Ontario? And how do we get things to move along this model in Ontario? Where do we start?
Yeah, so I'll reference the Langley Village is what I would say is probably the best example in Canada. So that was the one I put up on the screen in British Columbia in terms of being the most aligned in values and achieving those values as the Hogeweyk model. Okay, so I put those two closest together. I chose Tideview in Nova Scotia to flag just because it's the opposite of Langley, for-profit, non-profit, private, et cetera, achieved through with the province and without the province. In Canada, so in British Columbia, I will come to the Ontario question mark. In British Columbia, I'll just flag Providence Living. Providence Living is working with the founders of the Hogeweyk at this stage. They didn't work with them on the design, but they're building a new home in British Columbia, following a lot of those principles as well. And the Hogeweyk has inspired many homes. So we can look to other jurisdictions like New Zealand and Australia and France and the United States. So we can look at more models, particularly for that cultural context and design context, including weather, as you mentioned, and not just the Hogeweyk model. But in Ontario, there's been more of a lean into the butterfly model. So I think you folks have advocated in support of that. I've had the benefit of visiting the butterfly homes and greenhouse homes and all of those different models around the world. And I haven't seen really somebody who is locked into developing the Hogeweyk model. And we have other models in Ontario like Schlegel Villages, which you're probably familiar with. And they've introduced like a main street, but it's on the interior, right? So you walk out of your door, but you don't walk outside to get to XYZ. And yeah, I think, your bigger question is how do we do this? And I would come back to right people in the right room. We need to find the operator who wants this, the operator developer who wants to do something innovative. They need to be of a profile that they really, in ideal terms, that they already operate and have a positive relationship and reputation with the province that they're in, so that the government relations piece can be starting from a position of strength. And then you need to find the mover and shaker within government who understands what this transformation means and is ready to help sort of navigate the inside of government decision making. And you really need to have a group such as yourselves that are vested citizens willing to give that citizen perspective and really helping to contextualize what the Canadian experience looks like and what we want it to look like in long-term care. Because it's wonderful to look at these other models around the world, but we've got to get our Canadian stamp on it. And we don't yet have that. So I really think you need a provider who has the strength and track record and reputation and will and vision. And you need somebody within government who says, okay, yeah, let's talk about this. And I would try to pursue a demonstration project. Try to get in Ontario somebody who wants to come together on a demonstration project. And I would challenge that group to do it within the same spending envelope that there is today. And if you find those people, call me. I love to be in that room.
Okay. Well, Aimee, you've given us lots to think about, and I certainly have enjoyed your presentation. I know Sam, I think Sam, you're online here, and I'm going to turn it over to you.
Thank you so much, Mark, Cloud, Aimee, for spending time with us this afternoon. The hour has gone by quite quickly, but thank you for the information that you shared, the inspiration, motivation that perhaps you've enabled in folks on the line today, and the questions that we've been able to get to. We haven't been able to get to all of them, but Aimee did leave her contact information on the slide deck, and you can find more in the recording when that is posted on the FCO website and CARP as well. So on behalf of the FCO team, the CARP team as well, our co-host for today, and Aimee Foreman, our presenter, I thank you all for spending this hour with us. And I hope that this presentation has inspired you to take some sort of action on humanizing dementia care in your community. As Aimee said, we're all aging. Aging is not an illness. It's not a disability, but we may need some assistance as we grow older. And if we can start now and humanize the experience for folks who are currently living and requiring some assistance in aging, then it'll make it better for the people we love, for ourselves, and for those still to come. So thank you, everyone. Again, I'm Sam Peck, Executive Director of FCO, and it has been a pleasure to spend this past hour with you. Thank you so much, everyone. Take care. Stay safe.